So luckily, there is a solution to all these problems. And you may have guessed it is prospective meta-analysis, or short PMA. And if you need more convincing that now is the time to learn about PMA, maybe these prominent voices will convince you, writing about PMA as next generation reviews and suggesting that all primary research shall be designed, executed, and interpreted as prospective meta-analysis. So what is a prospective meta-analysis? In a prospective meta-analysis, studies are identified as eligible for inclusion in the meta-analysis, and hypotheses and analysis strategies are specified before the results of the studies related to the research question are known. So quite a mouthful, but in short, the key feature of PMA is that studies are included before their results are known. If you have a look at this diagram, it shows 3 eligible studies, and a PMA can happen at any time before analysis, so before what is marked here as PMA cutoff. So either early on in the planning stage, or while studies have started recruitment, or even just before analysis in the data collection stage. So to get an overview of the current landscape of PMA, we conducted a scoping review up to 2018, and we found that PMA were on the rise, and that they have been conducted across a number of health research areas. However, we also found that the definition, methodology, and reporting of previous PMAs varied greatly. And we found that there was very little guidance on how to conduct PMA. And thus, that guidance was urgently needed. And this is why we, the Cochrane PMA Methods Group, have developed detailed step-by-step guidance on how to conduct PMA. And this guidance has been published in the BMJ and is available for further reference, and covers every step of conducting a prospective meta-analysis in detail. As you can see the step-by-step diagram here on the right-hand side. And we will now briefly walk you through these main steps of conducting PMA, with a particular focus on the steps that are different to traditional retrospective meta-analysis, because we assume that most of you have some experience in traditional meta-analysis. Now, before you even start a PMA, you want to decide that the PMA is the right methodology for your research question at hand. And generally, PMA should be considered for high priority research questions for which limited previous evidence exists and new studies are expected to emerge. And I think this is another, this shows again why COVID is such a prime example for PMA and where they are needed. PMA don't have to be passive, they can also be an active catalyst for initiating a program of priority research. So if someone identifies an area where PMA may be appropriate, they may motivate other studies in this area to be conducted. Now, once a decision has been made that to conduct a PMA, a research question needs to be defined and a draft protocol needs to be written. And importantly, this needs to happen before any results of the included studies are known, to avoid selective reporting bias and outcome-based selection of studies. Now is also the time to work on a Prospero registration record for this PMA. And Prospero actually has a feature indicating PMA. So you may even want to check if there are other PMAs in this area already. PMA can include interventional or observational studies and individual participant data or aggregate data. And for aggregate data, PMA, there's actually a separate framework that has recently been published, which I've shown you here at the bottom of the slide for your reference. Over to you, Kylie.
Okay, so similar to a traditional systematic review, a prospective meta-analysis should be preceded by a search for eligible studies. However, since PMA include planned or ongoing studies, searching can be a little bit more difficult. So clinical trial registries are a key resource to search, and I'll give a few tips on how to do this on the next slide. Eligible studies can also be identified by searching bibliographic databases for published protocols and cohort descriptions, and by actively approaching relevant stakeholders, and by publicising the PMA on websites and at conferences, for example. And as Lena said, a PMA can also motivate other researchers in the field to conduct a similar study. So As I mentioned, clinical trial registries are a key resource, and searching registration records is an important step in building a PMA. But it can be quite challenging, and there is a lack of clear guidance on exactly how to search registries. So to address this, we have developed a number of steps and recommendations to guide searching for registration records. We intend to submit this for publication shortly. But for now, I can give you a brief taster of some key recommendations. For those of you who might find this a little dry or technical, I've added another puppy picture for your enjoyment. So as a minimum, researchers should search clinicaltrials.gov and the World Health Organization's International Clinical Trial Registry platform. And this includes data from 18 recognised registries globally. It's important to be aware that these search interfaces have different tools and rules. So search terms and how they are combined needs to be adjusted for each. Secondly, we recommend avoiding, in general, the use of search filters that are offered by the registry, because these rely on accurate data categorization, and this isn't always achieved because there's no stringent peer review of registration records. So we did test application of a study type filter and identified that 3 out of 57 records were randomized controlled trials, but they'd been incorrectly categorized as observational studies. So these would have been missed if this filter was applied. So a third recommendation is to test whether your search strategy retrieves studies which you already know are eligible and which have been registered. And if not, the strategy should be revised in an iterative process. So if you'd like more information or advice, we recommend you check out our upcoming paper. But in the meantime, you can also contact us directly for advice and we'd be happy to help. So once eligible trials have been identified, it's then time to grow the collaboration. So we typically structure our collaborations as shown in the figure. So there's a central steering group who drives the project, an advisory group of invited experts and consumer representatives, and they provide guidance and feedback via regular meetings. And of course, we have the trial representatives, and they're invited to provide input on key aspects of the project. That includes the protocols, the analyses, interpretation of the results, and for this they are offered authorship in line with ICMJE requirements. So this means that PMA involve people, not just papers. And that's shown by these photos here of different collaborations that Lene and I have been a part of. So the aim is to bring people together to collaborate rather than compete. And this confers many benefits in addition to making things a lot more fun. But it can also present challenges when members have opposing views. So it is therefore essential to have an independent steering group with great project management and communication skills in order to build trust and engagement amongst collaborators.
So once a collaboration has been formed, this collaboration can then work together to harmonise key outcomes or other important study features. Or in other words, we can transform pears and apples into apples and apples. This can also involve trials agreeing on important rare adverse side effects that they may not have had the power, so they may not have analysed if they hadn't decided to collaborate in a prospective meta-analysis. Importantly, collaborating in a PMA and harmonisation does not mean that all studies have to share exactly the same protocol. Instead, it's just really a few key elements that studies decide to harmonise. Local variations in protocols are still possible and can often be desirable because they can improve generalizability. And studies may have particular focus areas, they have additional resources they may want to look into, or locally relevant questions that don't have to be addressed by all trials. The ability to harmonise, of course, depends on the stage at which studies are included. So either very early on at the top, in the top diagram, if all studies are included in their planning stage, that will be a de novo PMA. And those PMA often have studies within that often have very similar protocols and sometimes even follow the same protocols. Or if you have a PMA of mostly completed trials, you may be able to have some harmonization of outcomes or add a few core outcomes, but not so much. In reality, we often actually see PMA that are not like the top diagram, but the bottom diagram. So studies are happening at different times. And in that case, you may be able to harmonize later studies to agree a bit more with earlier studies and can still have some harmonization in, for example, populations of those ones. Now, I'd like to give you an example of prospective meta-analysis and how positive harmonization can be. The example of the early prevention of obesity in childhood, short EPOC PMA, which was the first prospective meta-analysis in very early childhood obesity prevention, which found that early interventions can in fact reduce BMI-Z score and other weight-related outcomes at 2 years of age. And in the EPOC PMA, the trials were planned individually before they knew about each other. So they all had independent protocols or registration records. But then they decided to collaborate and work together shortly after. So they were kind of the diagram in the planned but not finished stage. And this gives us the unique opportunity to see how the decision to collaborate in a PMA influenced our ability to meta-analyze these studies, because we have those independent protocols or registration records. So here you can see the outcome harmonization before the decision to collaborate in a PMA and after. So the table on the left-hand side shows you the key outcome categories and the number of trials, collecting those before and after. And as you can see, whilst previously only 2 of the outcomes were collected by all trials, afterwards it's almost all of them, 10 out of 11. So here we have a real-world example of how the decision to collaborate in a prospective meta-analysis strongly increased our ability to meta-analyze outcomes and find meaningful results. All right, so in our diagram, step by step, we're now in the waiting period. We have harmonized, and we're just waiting for the individual studies to be completed. And this is usually a period that's not very time intensive for the central PMA committee. Sometimes, however, you may have joint data safety monitoring committees across trials, or at least data safety monitoring committees that communicate following pre-specified rules. So now we've finished waiting. We're getting to this exciting point where we have results of trials available and we can synthesize the evidence. And this process is similar to the one in a normal meta-analysis or a normal IPD meta-analysis. However, it's often actually easier due to harmonized outcomes and the stronger collaborational support. Then once we've synthesized outcomes, we want to interpret and report them following the PRISMA reporting standards. But as well as the standard PRISMA items, authors of PMAs also need to report on some of these key steps, such as how the planned ongoing trials were identified, the PMA timeline, the collaboration policies, and outcome harmonization processes. And we are, in fact, currently developing PMA-specific PRISMA items to address these additional steps. All right, congratulations. You've made it through all 7 steps. Hopefully you are still listening. And you should feel as proud of yourself as my puppy Charlie after her first surfing lesson. You can see her from just lying on the board to standing up. She may not have realized that surfing is actually a water sport, though. We now have a quiz for you, just to see, to test your knowledge on PMA and to give you a little break from hearing us speak. Again, it's Slido, so it'd be great if you could answer this question: when do studies need to be included in a PMA? And only one of these answers are correct. So you can join using the same procedure again and tell us when do studies need to be included. And we have the first answers coming in. I'm not telling you yet whether they're correct. Okay. So we may actually It's actually an interesting question because maybe we should have asked it slightly differently. We should have said when the studies need to be included as a latest in a PMA, because you're right, all of these times are correct. They can be included any of those times. However, they should be included as a latest before results are being known. So in a way, I think we are wrong because we asked the question but wrong. You are right. But what we're trying to bring across here is PMA can be, studies can be included at any of those time points. However, they need to be included before the results are being known. All right, the next question. What is the main resource for searching for unpublished studies for inclusion in a PMA? And this should just automatically update on your Slido if you still have it open. I think this one was too easy, Kylie. Or maybe you've just presented really well on this point, so seems like everyone's getting it right, which is great. Let's just blame Kylie's presentation skills. All right, thank you all so much. Now I'll hand over back to Kylie.
Thanks, Lena. So after having gone through all of these steps, you may be thinking, so why would I do a PMA instead of a multi-centre study? That's a good question. So both of these approaches do have many similarities, but there are also some key differences, which I'll go through now. So as I mentioned before, PMA should be preceded by a systematic search, whereas for multi-centre studies, these usually happen in isolation, regardless of any other similar ongoing studies. And because of this, PMA are more efficient because they combine and adapt currently planned trials to answer additional research questions. PMA are also more flexible, so since they allow study-specific protocol variations and collection of additional outcomes that are locally relevant. And then in turn, these variations increase generalizability of the research findings, so they have higher external validity. I'd also like to reiterate some of the key benefits of PMA compared to traditional retrospective meta-analyses. So that is, PMA are less biased and more collaborative. They allow increased harmonization of outcomes, and this can increase statistical power to detect effects and allow analyses of rare outcomes. So I'm now going to talk through some examples of PMA to illustrate how these advantages play out in practice to generate highly impactful evidence. So the neonatal oxygenation prospective meta-analysis, known as the NEOPROM collaboration, was formed to address over 60 years of uncertainty regarding the best range to target oxygen levels in preterm infants. A large sample size was needed to detect a difference in mortality, but no single funder could finance a trial of this size because the blinded oximeters that were required to measure the interventions were very expensive. So instead, 5 international trials came together to conduct the first prospective meta-analysis in neonatology. And these 5 trials are shown in the table on the right, together with their respective sample sizes. So importantly, the funding for each of these trials was contingent on their involvement in the PMA, since this enabled sufficient power to evaluate important outcomes, such as mortality. So we have a forest plot on the next slide, which shows the outcome of death by 18 to 24 months corrected age. And we can see that no trial alone found a significant difference in death, as indicated by all of these confidence intervals crossing 1. However, in the combined analysis, so with the diamond at the bottom, it showed that a lower oxygen target range was associated with a significantly increased incidence of death, and thus the higher target was favoured. And this evidence is now used to inform decision-making and practice, and has been highly impactful given that oxygen is the most common drug administered to preterm infants worldwide. Another example is the cholesterol treatment Trialists collaboration. And this brought together 30 trials evaluating statins. And these trials comprised a total sample size of around 175,000 participants. And this was formed after investigators realised that no individual trial would be large enough to detect differences in important safety and efficacy outcomes. So the collaboration found that statins substantially reduce the risk of major vascular events and death in a wide range of people, and that they are safe. And these findings have led to worldwide uptake of statins in at-risk populations. And in fact, as many as 50% of US men aged 65 to 74 years now take statins. And this uptake has prevented millions of deaths worldwide. Back to you, Lene. Oh no, here we've got the word cloud. So yeah, this is testing how much you've been paying attention. If you could name some advantages of prospective meta-analysis, type them in here. I was worried people weren't there anymore. Great, here they're coming through. Convenient, powerful, harmonisation, excellent. Easy, well, yeah, can be. Fast, accurate, less research waste, collaborative, less biased, excellent, flexible.
And I have to take a screenshot of this one. It's very beautiful.
Definitely, definitely.
Should I go to the next one?
I think, yeah, in the interest of time, probably have to move on, but yeah, very interesting. Thank you. So now we have another quiz question. So please, if you could select the correct statement regarding PMA, and only one of these is correct. We potentially made this one a bit easy as well.
Yeah. Everyone's listened, so that's great news.
Excellent.
All right, let's move on just in the interest of time. So we have some question time. So let's talk about the future of PMA briefly. With new developments, we see new horizons for PMA. First of all, there's increased trial registration. In a recent audit, we found 95% of trials registered before trial completion. So they would have all been identifiable for an inclusion in a PMA. And we actually see movements toward registration of observational studies as well. So I think we have more ability to identify studies for inclusion in PMA. They will become a lot easier. In addition, we see improved collaboration and data sharing abilities. I think maybe the most prominent one is that a few decades ago, we would have had to go through papers like shown in this picture and physical mail to be able to collaborate with each other. Whereas nowadays, we can collaborate in real time, talk to people around the world, such as we're doing right now in this webinar. We could also would like to briefly talk about how PMA can be combined with other innovative methodology. And the most obvious one we've already mentioned a few times is individual participant data. Individual participant data involves the collection of row-by-row data shown in this graph below. So you have data for each participant. And meta-analysis of IPD is often described as the gold standard, because it allows additional analysis, improved data quality, and in particular subgroup analysis. Both IPD and PMA are usually collaborative approaches that involve forming a collaboration. So if we already have a collaboration that's working together to harmonize the outcomes, it's often an easy step to also get this collaboration to work together to share their data and conduct a gold standard IPD. And that's why often PMA are conducted off IPD, but not always. But we can also see possibilities for a combination of PMA with other methodology. First of all, there are nested PMAs, which describe the combination of retrospective with prospective evidence. And this is appropriate in circumstances where we have too much evidence already out there to just throw it all away, because we feel that would constitute research waste, but not enough yet to answer the research question. So in that case, we can combine some of that retrospective evidence with the prospective advantages of PMA. We also can see possibilities for living systematic reviews for PMAs. So living systematic reviews describe systematic reviews that are frequently updated following pre-specified rules. And living systematic reviews address very similar research questions to PMA. So high priority questions where a lot of new evidence is expected to emerge. So it may be a good idea. So these two methodologies may be combined by systematically adding newly identified planned ongoing studies to a PMA until we feel we have sufficient power or expected power to answer a research question. But also other new methods, such as network PMA or PMA of prognostic models, could be combined with PMA, because it may enable collecting additional variables or collecting them in a way to make these methods more powerful. Generally, we can see PMA as a way to design priority programs of research. Now, I just briefly wanted to also mention Cochrane's role in these methods, particularly PMA. Cochrane has long been the home for methods groups, and we believe that Cochrane and the methods community need to continue to work together to facilitate the appraisal and uptake of these novel methods, so Cochrane can remain at the forefront of systematic review methods in healthcare decision-making. And we have discussed further how exactly we think this could work in this editorial, if you're interested. Now let's briefly come back to the example of COVID-19 and why this is a prime example for the need for PMA. For COVID-19, there was no previous direct evidence, and there were unpredictable case numbers of COVID within centers or countries. So it was very hard to set up one big trial because hotspots would emerge, but also fade very quickly. There was an urgency to collect the same outcomes using the same measures, including rare adverse side effects of treatments potentially, and urgency to combine data rapidly. So in short, we needed to collaborate instead of compete, and we still need to do so to overcome this global pandemic. Now, we had a look at how well researchers in Australia have listened to those calls for collaboration. By looking at the landscape of COVID-19 trials in Australia, we looked at all trials registered in the first 9 months of COVID-19 on trial registries. And we found that whilst there was an impressive research scale-up with lots and lots of trials registered, only 21% of these trials plan to share data upon completion. So those calls to coordinate international research efforts and share IPD seem to have gone unheard by many Australian researchers, at least. We also found relatively small sample sizes, which would not yield enough power to detect differences in meaningful clinical outcomes, such as mortality, and a lack of collection of common core outcomes, which Kylie has already pointed out to you earlier on, includes evidence synthesis of these smaller trials. So in summary, we found that the research design was not sufficiently strategic or collaborative and may have led to taxpayer-funded research waste, and that coordinated efforts are urgently required to still address COVID-19, but also future health emergencies. Otherwise, we may again see headlines such as this one. Now, but let me finish with some more positive examples. So luckily, whilst it seems in Australia some things have gone wrong, and I would like to say that was an overview of trials in general, so there may have also been some more positive examples. The framework that we've developed for PMA, the step-by-step guidance, has actually been taken up by researchers to develop step-by-step guidance on how to conduct PMA on COVID-19. And we are aware of quite a few PMA on COVID. And I'd now like to just give you one very positive example of how this methodology has been used to improve the treatment of COVID-19. So this is this PMA was published in JAMA and was on corticosteroids to treat critically ill COVID-19 patients. And what this group did is they searched trial registries for relevant trials and formed a collaboration very early on in the pandemic. And then they had weekly calls to harmonize their protocols, outcomes, and subgroups. The trials then shared outcome data for pre-specified outcomes and for pre-specified harmonized subgroup analysis, which enabled participant-level subgroup analysis that avoided ecological bias. And impressively, their final PMA article was published online less than 2 months after the date of final follow-up, showing that corticosteroids were in fact effective in treating COVID-19, in lowering 28-day all-cause mortality in COVID-19 patients. So a really great example of how this methodology has been applied to an urgent health research question. Now, before I open up to questions, I would just like to summarize a few take-home messages. So PMA can reduce research waste, and they're adaptive, efficient, and collaborative. And we would like to encourage you, when you start a new study, to ask yourself, is anyone else doing this? And if so, how can we collaborate? Because the beauty of collaboration is that we bring together more expertise and more statistical power, which can lead to more influential research. And we would like to acknowledge the Cochrane Prospective meta-analyses methods group. All the work that we have presented constitutes joint undertaking by this group that has been around for many years. All right, feel free to contact us for guidance on PMA. I hope you haven't fallen quite as asleep as Charlie here. And we would like to open up for questions. And I think, Ella, you were going to moderate that.